This podcast does not provide medical advice. The information included but not limited to any videos, text, graphics, image materials, or any programs or consultations contained within this podcast are for information purposes only. The podcast does not constitute providing medical advice or professional services. It does not constitute a patient-physician relationship. If you have medical concerns, please seek out your private physician, or if you feel you have a medical emergency, please contact 911. Welcome to Kars Koaching, the podcast where we combine our love for cars, medicine, and self-development to get you to the life that you deserve. Hey guys, welcome back to another episode of Kars Koaching. My guest today, I'm very happy to have Dr. Faisal Saghir with me. Faisal is a colleague. I used to work with Dr. Saghir, and I consider him a friend. I don't know if that's reciprocal, but so Faisal,
yes.
If you'd like to go ahead and actually introduce yourself, I'm sure the audience is eager to find out about you.
Sure. My name is Faisal Saghir. I'm a medical oncologist, hematologist with Northwestern Medicine. Both Dr. Coolidge and I worked at the Kishwaukee Hospital together. So I've been there for 7 years now. Been in practice for about 15 years or so in oncology. So
Faisal, I know we know what hematology oncology is, but for the audience, sometimes they get confused which piece is which and what does that actually mean. So if you'd be kind enough, everybody knows what a family practitioner is, but not everybody knows what an oncologist is.
Yeah, so I get a lot of patients who are referred to me, and they come to the clinic and it says cancer center outside, and they're like, I didn't know I had cancer, so why am I here? So yeah, I think it's an excellent question. So where the two fields are joined, hematology is more a field, of disorders of the blood, and oncology is a field of, of cancer therapy. Where they're joined is a lot of the blood cancers actually fall, under hematology too. So as a big specialty, it's still a cancer specialty because we are dealing, with blood cancers too. But then when we're dealing with blood, there's a lot of diseases or, issues that are not cancer related. So clots and anemias and, iron deficiencies and thalassemias. And so there's a lot of hematology that is what in medical terms, is called benign hematology, which has got nothing to do with cancer. So we see a lot of that too. So in fact, I think 30 to 40% of our practice is, benign hematology, where we're dealing with DVTs, pulmonary embolisms, iron deficiency anemias, thalassemias, protein S and C deficiencies, lupus anticoagulants, and all the rest. Yeah. Right.
So what part do you like better, the oncology part or the hematology part?
Yeah, I think that it's I like both, and I think that the way the field has evolved, I think it's you have to now, sort of select because it's the explosion of information and research in each of, the different disease, categories has made it difficult to, one person to stay on top of all the medical literature. So I predominantly do breast cancer and lung cancer now, and I do a lot of, benign hematology. My focus is not so much on malignant hematology, so I'm not practicing leukemias and lymphomas as much. I have a colleague who does that at our cancer center. So for my focus right now is mostly on oncology and benign hematology.
It's actually interesting that you say that, because that was one of the things that was impressive, and I think that's one of the good things about Northwestern, even though all of you went through that training. But like you said, you yourself are primarily breast and lung, whereas Bob, that you were referring to, does more blood. And it is, in the olden days of medicine, they had stated that in order to double, this was in the 50s, they said it would take 50 years to double medical knowledge. And now I was reading something that says something like 79 days. Yep. So there's no way for you to be able to be the specialist that you need to be for the patients or for yourself. So that is interesting that you do that.
Absolutely. Yeah, no, I think the explosion of information, the way you stated is very correct. I think if you're out of touch for 90 days, you're really very far behind at that point. So,
So I'm glad I don't practice anymore. So my stupidity, I have an excuse for, but it is. So why medicine? Why medicine to begin with? Did you always want to be a doc?
I don't know. I don't think so. Okay. I don't think that in high school I was looking towards medicine as a career. But my father is an anesthesiologist, and I had a lot of exposure to medicine. And he would come home and he would, talk about his day and his patients. So that I think did influence me eventually. I think when I had to make a career choice, he never pushed me to take medicine as a career, but he did say that it's it's a very gratifying career. And so I had a choice between being a mechanical engineer, which is I think what I really wanted to do. But at the last moment, I think I took my dad's advice, and I think I made the right decision.
So your dad didn't influence you as long as you were a lawyer, an engineer, or a doctor, right?
Yes, that's exactly
I was talking
how it
to
is.
somebody else the other day, and they said the exact same thing. They didn't care what I became as long as it was one of those
not
three.
Not even a lawyer. It was just an engineer.
Oh, just an engineer or a
physician.
doctor.
So
right.
there were just two choices. But yeah. I think I'm glad I chose what I did because it's been a fun journey.
So how did you go from medicine, obviously, and then how did you pick oncology?
Yeah, so my first exposure to oncology was during my intern year, just out of med school, and so I was in Pakistan at the time, so a resource strapped, country. So I was practicing in the largest city in the country, like 10 million people. And there were 3 fellowship-trained oncologists in the entire, city.
Wow.
So I was taking care of a couple of young patients, a young lady with breast cancer, with metastatic breast cancer, with 2 young, children. And so I was the one, preparing chemotherapy for her. And I mean, this is many years ago, back in the mid-90s. And they really, at the time, my impression of cancer was if you had cancer, it was pretty much it. And there was nothing you could do. And she actually did well with chemo. So, the cancer got better. I used to take her to her appointments. She used to come to the hospital for chemo, and then I used to take her to the clinic for the, oncology visit. So that piqued my interest, and I got to see a side of oncology that I wasn't aware of, the side where you can actually help people. And then the second part was the challenge, because it was I felt was the most challenging field in medicine because there was so little you could do, and there was such a lot that needed to be done, and it was never going to be mundane. Like it wasn't going to be like an endoscopy every day, or a colonoscopy every day. It was never going to be like that. It was always going to evolve. So that was the reason I took it up, and I don't think I can ever do anything else. I mean, it's just been such a gratifying experience for me to be in this field. I think looking back, I would do this over and over again. I mean, if I had a choice to choose a different career, I probably would not. I'd keep doing this.
When you entered medical school, I know you said it was the internship.
Yeah.
That when you entered, did you have an open mind of not knowing what you were going to do, or did you go towards a certain track when you thought you were going to be a doctor? You said, when I went in, I was going to be a plastic surgeon, right?
Yeah.
And ended up being an ER doc. Did you were you going to follow your father's footsteps into anesthesiology, or?
No, anesthesiology was something he said wasn't
for you.
wasn't the field he would select for me. But I was interested in ophthalmology too. Yeah. And that was when I was in med school, because I found it very fascinating with the physics. Because with my interest in engineering, I think the optics, and the physics with the eye was very appealing, because there was a lot of physics involved in ophthalmology. But then when I did the oncology rotation during my internship, I mean, to help people at that level was a different experience.
I think that's actually interesting, because I get a lot of questions from younger kids or kids that are in medical school that follow the channel, and they're, I'm going to be this and I'm going to be that. And I think it's great to be able to pick that. It would be interesting to actually do a study and see who actually sticks through with all of that, because I think the key is to have an open mind, and when you go through the externships, to be able to say, hey, I really like this, or this isn't really for me, even though I thought that it was. It's funny, my sister was going to follow in my footsteps, be an ER doc, and she did a rotation at the end of her senior year, and long story short, she became OB-GYN. So I think you really have to approach that, especially for the young med students out there, with an open mind, to be able to see what the right fit actually is.
Yeah, no, I think you're absolutely right. I think the exposure helps too. Like, you may have a particular interest based off of sort of limited information about that specialty, but when you actually go into that specialty, you may find it not to be to your liking, because there's certain sort of elements that may not be something that you had known about, right? So ophthalmology for me is still very fascinating, but I wouldn't select that over oncology. I mean, I just feel like I made the right choice with that. I think the spectrum of, oncology from, head to toe, so you're not really confined to, if you go to an ophthalmologist for a cough, you probably, that person wouldn't know what to do.
You have to look it up in the dictionary,
exactly,
right?
So I think, the spectrum of what we do is, is also pretty large. So I mean, that's I think you have to experience it. I would say to the medical students is follow the passion, and experience it. And if you fall in love with it, just do it. Because sometimes I feel that because of the student debt and all that, it's hard to pick a certain thing, because of reimbursements and all that. But this is a long-term game, It's not a 5-year, or a 7-year project. This is the rest of your life, and you have to, we'll talk about the burnout. But if you're in, a specialty for, like if it doesn't excite you, you're going to get burnt out very quickly. So it has to excite you every day. You have to feel like that's where you belong.
Yeah, and I think a lot of that, obviously, we've talked about this numerous times, about mindset and the importance of how you look at things. And somebody may look at oncology and think, geez, how could you do that day in and day out? And does it cause you to be burned out? So what's, not that it's a secret, but when physicians have to take care of someone, they have to be empathetic, but at the same time, there has to be a disconnect, right?
Yeah.
Because if you don't disconnect, I guess there are cases where you could actually sit in the room and cry with the patient. I get that. But if you did that with each patient, you'd never get through your day.
Sure.
So how do you approach that so that you don't get burnt out and you don't get depressed each time you go in? And I could imagine a lot of it's the satisfaction of the good outcomes, but how do you handle that?
Yeah, I think that's an excellent question. I think most people struggle with that. You have to disconnect at the end of the day. You have to, otherwise you will not be able to do, what needs to be done. So the way I handle it is I don't focus on the end result. What I focus is, focus on the journey. And the end result for, some of my patients is very unfortunate. I know people who have died of cancer that are younger than me. And so it's very, very hard. But what you focus on is what you brought to them or for them, during that journey, from the time they were diagnosed, So if you help them along the way, and if they were able to, enjoy the time that they were given, focus on that, as a physician, right? So you find some gratification there, that even though this person, had a premature, death, that from the time they were diagnosed, they were able to do some meaningful things in their life, that with the ones they wanted to do, so spend some time with their kids, or if they want to take a vacation, and so focus on that. And but at the end, it still hurts, to lose, a patient. And but you have to learn to disconnect, because you have to.
Yeah, I think that's a very good way to look at it. You're assisting them during the journey, as opposed to, and if the outcome comes where there's a cure, fantastic.
Yeah.
But if you just look at the outcome, because let's face it, all of our outcome is going to be the same, right?
That's exactly.
That's
my
one thing
point.
we're born with, is a death sentence. We just don't know when or where.
That's exactly right.
If you concentrate on that, it'd be extremely difficult.
Right.
So, stress. We kind of touched a little bit. We talked about burnout, stress. 80% of all health diseases, somehow stress, there's a component in it, whether it actually contributes to the disease or helps cause the disease, etc. How much do you think stress plays in its role in oncology?
A lot.
Okay.
I mean, it's stressful just to walk into the cancer center.
Yeah.
I mean, just the word cancer on top of your head, as you're walking in, that's stressful.
Right.
The fact that, like, it reminds you, I mean, most of us, as you said, are, have locked away, the thought of death, but it becomes very real, when you get diagnosed with cancer, even if it's early stage. And I tell my patients, they're not going to die of this. We have the ability to fix it, but it becomes very, very real at that point. And, and that's a stressful emotion, So stress is something we manage, for our patients, every day. And we have a lot of support, with our social workers and nurses and MAs, everyone chips in. And I think you have to refocus on what we can do versus what we cannot do or what we cannot deliver. And trying to, remind patients that there is a lot that we can do. Some conversations are harder than others, and it's always challenging, but getting the team involved, having their primary care physicians, having their extended family, having the social services support, just kind of, trying to gather, all the support pieces that patient needs, helps. I think the biggest support structure really for anyone at that point is their family.
Right.
And if they have a good supportive family, they've got a spouse, they have, children, they have parents that are supportive, I find that those folks usually do better with stress. It is harder for folks that are, living alone, gets to be hard. So, but we have resources for those folks as well.
Mindset. Patient's mindset.
Yeah.
Have you seen that? I mean, we all know that mindset obviously is going to play a huge role in their disease process. Have you seen where the obstacle was so great, but that mindset just wouldn't quit, and there were outcomes that surprised you? And then the opposite, perhaps, where it wasn't a diagnosis that you expected to be terminal, but they never got over that concept of cancer and the terminal nature of it. So when you talk to the patients about mindset, how important is that to be able to get them to, we talked about controlling the stress, but their actual outlook?
I mean, that's a fantastic question. I think that, so what I've seen a lot is for folks who have a terminal diagnosis where, they know that they have a limited time. When we have that discussion, when the time comes to have that discussion about, whether further treatment is futile or it's, or not, and then if you come to that conclusion that further treatment is not helpful for them, or there are no further treatments, I often feel that the will goes to because it's almost like when you realize you've come to the end of the road, you try to will yourself through a lot of times when you know that there are options available. But when you hear that there isn't anything else, and when the will to live goes, I think the body goes very, very soon after.
Yeah.
I mean, I've seen this so many times where I've had someone come to my clinic and they've been ill and ill and ill. I mean, they haven't been doing well, but the will to keep going is there.
That's right.
And then you have that conversation with them that, maybe it's time to reconsider, all the fight. And I hear 2 days later they're gone.
Yeah.
So,
they
so nothing changed in those 2 days. I mean, they were the same person, but they, in their mind, they just made peace.
It was interesting. I was reading it. I read something. This is not a study. This is
Yeah.
not, even though I got doctor in front of my name, it wasn't in a medical journal. And I can't remember where I heard this,
Yeah.
but it was something that I may have talked to you about when we had our monthly meetings and when we were working together, is that they had a misdiagnosis of certain people. And they said that they had a certain type of cancer, and they gave them that time frame, right? You've got the average is 3 months, 6 months. And most of those people died within 1 or 2 standard deviations of that. And then on autopsy, they realized it was a misdiagnosis.
It wasn't even cancer,
and
right?
it wasn't cancer. So, and I don't know the statistics, so I don't want anybody to cling on to that.
Yeah.
I will look at that and re-mention it. But it's that power of suggestion.
Yeah.
Like you said, that, hey, they're moving along, or you tell somebody else they have cancer, and if they give up with the will, it's 2-3 days, it's over.
It sure is. And I had this unique case of a patient of mine. I'm not sure if you have time to go over the patient stories, but
I got nothing but time. I don't work anymore.
So this patient that comes to mind, she's a patient of mine with breast cancer, and she comes to me and she says her husband needs to see me. I was like, what's wrong with him? Well, he's not doing so well. He didn't have a diagnosis of cancer, but she's like, he's losing weight, and I think he should come and see you. I was like, okay. And so he never came to see me, but 3 months later he did. And, so the moment I saw him, I was like, this gentleman does not look healthy at all. So we transfer him to the ER, from my clinic.
Where else do you send those people on TV?
I know. So, yeah, we do that a lot, actually. So he was diagnosed.
All of a sudden, we're smart when you guys do that, but when we call you, we're not. I'm sorry, go ahead.
No, it's good. So I sent him to the ER, and he eventually gets diagnosed, with melanoma, which was metastatic, and he never left the hospital. He actually died in the hospital. But my patient, who had been married to this, to this gentleman for 50 years, he was the support structure for her. She died 2 weeks after he died.
Yeah.
And she didn't, have cancer that was, uncontrolled or was not in good control. She was doing well, but I think her will to live went with him, I think. And
it's like they say, die from a broken heart.
Yeah. So yeah, that was so there you go. There's a lot of mind over matter thing.
Yeah.
So yeah. Yeah.
We talk a lot. I know I've shared with you the My Focus model. We did that when we were working together in my coaching model. And when we look at things such as diet, stress causing cancer, sleep, what are some of the factors that people could control in their daily life that actually can at least help prevent or stave off cancer out of the big ones: sleep, diet, nutrition, and exercise?
Yeah, I think all of them are important. We have a lot of research. I mean, most of the research is in the bigger cancers, right? For instance, breast cancer. There's plenty of research telling us that, being overweight, smoking, unhealthy diet with, high, fat content are all risk factors for breast cancer. So, all those elements that you mentioned, each of them, play a part in increasing the risk. So, can you, I don't know if I can make a top 4 list, among that, but
please.
I think all of them are just about equally important. And I mean, with breast cancer, the science is that when you have a lot of fatty tissue, you tend to convert, a lot of your hormones into estrogen, and, the estrogen, activity goes up, and, there are more estrogen receptors. And so, so I think there's a link that I guess the hypothesis is that could increase, the risk of breast cancer. So part of what we do when someone gets diagnosed with breast cancer is tell them to eat a healthy diet, and if they're overweight, is try to, emphasize the weight loss. I think for lung cancer, it's so driven by smoking that I don't think people have focused on the diet and exercise as much. But I can't, I don't think there's going to be, there's not going to be a link, right? I mean, because unhealthy diet. So for instance, again, going back to breast cancer, the rates of breast cancer, or the incidence of breast cancer in the U.S. is a lot higher than Japan. But when the Japanese women move to the U.S., the rate equalizes.
Right.
So the theory has to do something, with the diet that
Western
we're consuming.
diet, yeah.
So, yeah.
Yeah. No, and that's actually interesting, too, from a longevity perspective, when they look at chronic disease, right? And cancer being one of the chronic diseases, is a lot of it is tied to the Western diet, right?
Yeah.
Because if you're isolated and eating off of the land, theoretically, you don't get all of these quote-unquote chronic diseases and different types of cancers. And and the other thing is sleep. I think it's in Matthew Walker's book, Why We Sleep. I believe it's Sweden, and I'm not sure if you know this, that they actually, lack of sleep or the night shift is considered a carcinogen, and they take care of all of the nurses that have succumb to breast cancer, etc., because of that. So I think there's a lot of things that we take for granted that we can do that really isn't that hard. And a lot of it is maybe not doing things. It's just don't do things, right? So just, don't stay up late. Go to sleep. Going to sleep's pretty easy, if you can do it. So.
I think that. So one of the things that stress does is, it weakens our immune system, right? So there is a link between a weak immune system and excess number of cancers, because the concept is that each one of us, well, if you're my age, you probably have had one clone of cancer develop already. The reason that
So I have 2 because I'm 10 years old.
So the reason we don't get cancer is because our immune system takes care of it. So part of the reason why some of us will get cancer is because our immune system just wasn't able to detect it or fight it off. And so having, taking immunosuppressants, for instance, if you're, like for people with rheumatoid or some other conditions, I mean, we have data that those folks are at a higher risk of developing cancers later on. So, so anything that's going to interfere with our stress, with our immune response, I mean, if it's from stress or if it's from lack of sleep, it's potentially going to then increase our risk of cancer too.
Yeah. So it goes back to the basics. If we listen to what grandma and grandfather said, right? And for the kids these days, right? Get plenty of sleep, eat the right foods, exercise, then there's other things that still may get you, but at least you're going to end up having a strong base.
Right.
We kind of touched on burnout a little bit and how you as an oncologist have to deal with a lot of stress when you deal with patients. What do you do? First of all, do you see a lot of burnout with your colleagues in medicine?
Mm-hmm.
Yeah, I know. We
burnout
kind of came from the same place, so.
Yeah, burnout is common. I mean, it's the stress, the stressors of, at least, I mean, from my perspective, I mean, I haven't done a lot of research on, physician burnout, so I don't know the specifics per se. I mean, all of this is my personal observation, but I think just trying to juggle life, is because most physicians are very driven. They want to be the best at everything. So you have to be, the best dad and the best husband and, the best physician in the office. And it's that, personality that kind of drives you. And I don't think you can be the best at everything all in once, so you have to be good, but so I think you have to pick your battles almost, and so there are some things you gotta let go. Not saying that you cannot be a good parent or a husband, but then I guess the definition of that, has to evolve, right? Just because if you missed a game, for instance, I mean that, that shouldn't stress you out, So anyhow, I think that the burnout is all the stressors that are, at work, where over time, we've, had this erosion of autonomy of what we do. And you feel like you're doing more and more paperwork and not being able to help your patients. Like I saw that, like 2 patients yesterday where I wrote for something that, is FDA approved, but their insurance is, dragging their feet on approving it. And there's one guy with lung cancer who's got brain metastases, and he needs a pill, which is very effective for his disease. But his benefits through his insurance are $20,000 for the entire time, like for it, that's
forever,
it.
Yeah.
And he'll run out of those within 6 weeks, for the pill that he needs. So what happens after 6 weeks, no one knows if he's going to be able to. I mean, so these are just things that you're fighting, that we shouldn't be fighting. We should be focused on trying to get, people help that they need. And but we spend hours and hours on trying to find workarounds because the insurance is not going to approve things, and people are on the phone for hours trying to convince people to, help these people we're seeing. So it just, there's a lot of elements to that. And so burnout is very real. And I think what happens is you lose interest, and, you lose what the passion goes away. And then it becomes a rut, and then your productivity falls, and then you make mistakes. And it's a bad place to be.
Yeah, and then you're chasing your tail. Yeah, you're exactly right. There are certain personalities. It's if you're a perfectionist, if you're neurotic, or if you're an introvert. Those are the 3 that tend to get hit really hard.
I see,
And you touched on the other piece. It's the work-life balance.
Yeah.
And when I talk to a lot of my clients, I don't make it work-life balance because I don't think you're ever going to get a balance.
Yeah.
I think it's work-life integration.
Yeah.
How do you tie those 2 together? So because when you talk about work-life balance, it's almost like work is bad and life is good.
Yeah.
And you already explained that you have a passion for the oncology, but how do you keep that passion going? I like to tell people, remember the first time you did a procedure, a spinal tap, a chest tube, whatever it was. You were telling everybody, people on the bus and the elevator, they didn't even know you. Yeah. Now, we go through the whole day. We don't remember who we're helping. Yeah. We remembered what you said. Lack of autonomy, fighting with insurance companies, dealing with the EMR, poor relationships, right? Mismatch in values. You want to do something, they say from a financial perspective, you can't do that. Lack of fairness. You take all of those things into account, and we no longer remember the good that we're doing. So spend a little bit of time in a day and remember what you actually did good, and that may push you through a little bit. So.
I think that's an excellent point. With the integration that you made, because I mean, I don't see it as a work-life balance. I think work is life, right? So it's just balance.
Right.
So I, because I wouldn't enjoy life if I didn't have the work.
No, you have to do something.
Yeah, because that's what makes you productive. That gives you a little meaning to your life too. So I think just finding the balance is the thing. Is you need to have something besides work too, and you need to have some harmony between the two sides of your life. But it's not like work is bad and you got to get out of it to have a good time. I think it's for me, work is very good, but you just have to find the balance of how much, and have work sort of streamlined to where you feel that you're efficient, and you feel that you're that you're helping the folks that that's your primary role. There's a saying, right? I was so busy making a living, I didn't make a life, right? So it's kind of, how do you tie those two together? Absolutely.
Yeah. We started this podcast. You're our fifth guest, so we appreciate that. And part of it was our love for cars, medicine, and self-development. And it's funny because one of my previous guest, who's a client of mine, we forgot to talk about cars. So I have to remember not to forget about talking about cars, because sometimes I get tied up with the medicine piece. Sure. And that, I think, was, aside from the fact that we had a scheduled meeting when I was still working, one of the things that actually brought us together is cars. So I know you've got a Porsche, you got an Aston Martin as well, and I know you're a big car fan as well. So
absolutely.
When did you start getting into cars?
When I was 6.
When you were 6, sounds like my son, which got me in trouble through my dad.
No. So the first car that I remember that my father purchased was a big deal. I mean, was a 1976 Corolla. Yeah, it's a pretty good car at the time. So anyhow, so then he sold that. No. Actually, it was. I take it back. That was the second car. The first car was the ugliest car that I've ever been in. It's a 1968 Toyota Corona.
Corona.
Yeah, I don't think they make them anymore. But it was like a box with 2 lights in the back and 2 in the back. 2 in the front and 2 in the back. But my dad loved it. Oh my goodness! It was like this teal green color. It was horrible, and but it was a solid car. Like it took us everywhere where we needed to go, and he was very sad when he had to sell it. And my mom never liked that car. It was ugly.
Right.
And she wanted a prettier car. So he sold it for this 76 Corolla, which she really liked. And then I think his last car, which he never sold. And I moved out of the house, and so he had a Datsun 120Y. It was I forget the year it was. It was some late 70s maybe. But he kept that thing until the mid 90s almost.
Wow.
My first car that I paid out of pocket for was a 1968 Volkswagen Beetle, which was an amazing car. It was, the Volkswagen Beetle, so the Bug. And I kept it for a year and a half, and then I gave it to my brother. And he had it for a number of years before it was scrapped because it was just too old to maintain at that point. But
my friend had one, and not to interrupt it, the floorboards were gone.
Yeah.
So we used to have to go to the grocery store where they threw out the boxes and redo the floorboards, because if it was raining, we'd get all wet. So it was one. But they would drive. They would drive, right?
They would drive. I had one time I was driving, and the clutch, the cord broke.
Yeah.
So
yeah.
the actually, from the foot pedal to
Right.
to where it, connected with the lever. So I could only put it in second gear, and if I had to stop, it would be I couldn't stop. The car would stall. So actually drove it in second gear, navigating, city traffic. Finally came home. And one time, the fan belt went out, and it's an air cooled car, so it doesn't like heat a whole lot.
Right.
And I thought I was going to take it to the mechanic. I was like, I'm going to drive it to the mechanic. It was only 5 minutes away. I was like, I would make it without the fan going. Like I opened the back, I was like, let air
So you
in.
let
It's
it
air
cool
cooled.
off, yeah.
It caught fire. Before I
Before it went-
pulled in, it was a fire. There's this fire in the back. So.
Well,
Yeah,
no, that's actually that was the heater of those cars, right? The VW, the heat was coming off the engine.
Off
You
the
just
engine, yeah.
opened up, and there was no fan that was
Yeah,
heated
there was no
or
radiator.
anything. No,
I mean, it was just air cooled. Yeah.
Yeah.
So, but yeah, lots of fun in that car. And then over the years, I've had a Corvette, I've had a Maserati, I've had a 911.
Favorite out of all of those?
911.
Yeah. I'm starting to lean that way too.
Yeah.
They're just so practical.
Then
They're
dri-
practical and they're
they're
responsive.
fun to
so,
drive
yeah.
too. I think the Ferraris obviously are awesome, but
Yeah, but it's hard to take it for a
hard
gallon
to
of
take
milk.
it. Yeah, exactly. Yeah.
It's
I mean, the road clearance is better on the 911s,
Yeah.
and they're more practical, as you said, and everyday cars. So, yeah, I think a 911 is probably of all the cars I've owned, I think it's my favorite. Yeah.
cool. So you're in a leadership role at work, and all of us are really leaders, right? We have to lead ourselves. We lead others. What to lead doctors? What's the secret? What's your secret to get the buy-in from physicians?
Trust.
Hmm.
I think you have to earn trust. It doesn't come like that. You have to take ownership of your leadership role. You can't, if someone comes up to you, you have to listen, and you have to understand that you're the person for this guy, right? Or this, so it's challenging, because there are certain policies and procedures that everyone has to follow, and sometimes it's hard for a new policy to be implemented, to have buy-in from your team. But if your team knows that you're going to stand with them and stand for them, I think you'll have an easier time with the buy-in. If they perceive you to be part of leadership, it's going to be tough. So being a leader is not pretending to be a leader. I mean, you have to your team has to understand that you're a leader for them, that you're not a leader for the organization, right? So you're their voice, and that I think is being a good leader. It's not that you have to do it for the sake of the buy-in,
Right.
but that is, in my mind, the definition of being a good leader. And sometimes you have to push back, if you feel that your team is going to, if it's not good for your team, right? That you have to take a stand against the leadership that I have to report to. So I've been able to do that a few times, and I think, I feel like I've gained the trust of my team, and I would, but it takes time to gain that trust.
No, I agree with you 100%. I think
Yeah.
I think leadership is the influence piece, but you
Yeah.
cannot have any influence without trust.
Yeah.
And once that trust is gone, it's over.
It's
It's
over,
very,
yeah.
very hard to get that back,
No.
And I think well
Yeah.
said. And I know I've seen you lead when I was still with the organization that we worked for, and I think you do a phenomenal job. And I think that's a great tip to all the young people out there. And it's exclusive. It's not just medicine, anything.
Right.
That's exactly what you need. You need to be able to trust, even if you're leading yourself. If you don't trust yourself, if you don't have that self-confidence, right?
Yeah.
Confidence just means trust, right?
Right.
Then you're not going to be able to do anything. You won't be
Yeah.
able to influence yourself to do anything. So
Yeah.
I think very well said. Very well said. Known you for a while, successful guy. We kind of went through your history as to, you know, too bad you didn't become an engineer, but I know you're a tremendous hematologist, oncologist. Talk a lot about habits in what we do. What do you think was one of the habits or one of the qualities that you had at a young age that you could impart to others that actually got you to the point of where you are today?
I think perseverance. There's going to be challenges in life every day, and you have to stay focused. You can't, beat yourself over failures. You can only learn from them, and there'll be failures, lots of them. You just have to keep going, and it will take a lot of sweat to get to where you want to be. But if you have the passion and the desire to get there, I think you will. It's not going to be an easy road for anyone. So you can't give up at the first obstacle, or you can't give up if you fall, after the first hurdle. You can pick yourself up and keep going. So I've had lots of struggles. And I find myself to be very satisfied at this point where my life is in general. I don't think that there is any bucket list left for me. I'm very proud to be where I'm at. Very satisfied with the choices I made in my life. And there's a lot of contentment that comes with that. Now, that doesn't mean that I don't have any ambitions for the future, because you got to have a goal to strive for. And so I do have a lot of goals for the future, but there's also a lot of contentment for where things are today. But it's not easy. There wasn't anything that was handed to me on a platter, and no one should expect that, And so I think that's the old enough to probably say that now. So,
not that old, but yes.
It's
it's interesting because it's looking back, and I always tell people that if whatever you're attacking is like a stock chart, that's good. Right? Yeah. As long as it's moving in the right direction. Yeah. So everyone thinks, especially the young kids, right? And this isn't to pick on them, but it's that microwave society where they want everything right away and they don't want to fail and everyone gets a trophy and all of those things. And they don't go through those failures, but it really is. It's like a good stock chart. Up, down. Up, down. Then you build a base. Then you go up again. Then you go down. But as long as you're moving in that right trajectory, that's what life is. And the other thing that you captured, which I think was extremely important, is goals. And I think physicians go through so much training that when they finally finish, there are no other goals because it was so hard to get to where they're going, and I think that eventually takes them down because they get into that rat race. So I think it's extremely important, just like you said, to continue to have goals no matter what your age is, right? And if your goal is just to wake up in the morning, that's a tremendous goal, right? But you should always set goals. So.
And one other point I just want to make on the failures is that you do also have to be pragmatic. So for instance, for me, I was really into sports, so during my med school days, I was passionate about tennis. I was, passionate about cricket. And in cricket, which was my biggest passion, there is a lot of strategy involved. And, I was a good leader. I was the captain of the team. So I would strategize, our game very well. But I wasn't a good player, right? I just didn't have the talent.
Right.
So I realized that. I was like, I am not going to, if I keep trying in cricket,
Right.
I'm not going to get the outcome that I want at the level I wanted. So sometimes you have to pivot. I mean, if you give it a try and you try and try and try and you feel like, you've put in your best effort and you're not getting somewhere, you got to, sort of reassess your whole thing. And you said, maybe this isn't for me, right? So that's where sometimes you have to draw the line and say, okay, maybe this failure and failure and failure, may not be, eventually what I want to do. So, I realized that, in my sporting activities, that I just wasn't blessed with the talent that other people had.
Right.
And they would come and they would play better than me, and I would say, I tried. So I think that's that too. I think that having that foresight and and just knowing what your strengths are,
Right.
and really building on your strengths, not getting frustrated over your weaknesses, right? Because each of us has a strength. We just have to figure out what that is. And for me, I realized around there that it was more my brain than than my physique. So and so I focused on building that versus getting frustrated over not being a good cricketer, for instance. So I think you have to, if you're young, you got to figure out what your strength is, and then take it to the most you can take it to. So
well said. Yeah, I think it's being optimistic, but have a level of realism, not delusion.
No.
Right? Because a lot of times, everybody says, "Oh, optimism, you could do anything."
Yeah.
Well, I'm not going to be the center of the Chicago Bulls anymore at my age, right? So you have to kind of pick and choose.
Yeah,
I think that was very well said.
You have to really try to, work with your strengths. And there's talent in each one of us, so you just have to realize, where our talent lies and then build on it. So,
I agree.
Yeah.
I know there were some questions from Instagram. We actually, as we're getting more advanced in this, dipping our toe in the water, and that's exactly what we're doing. We're going up, we're going down, we're going up, we're going down. But there were a few questions that I'll have Michael read.
So somebody asked, what are some of the effective ways to prevent cancer? And I think we kind of maybe touched on some of that with sleep, diet. Is there anything that you would recommend besides that stuff that would be?
So I think about a third of all cancers are, environmental. So for instance, melanoma, sun, so use sunscreen, right? So smoking is probably the biggest environmental risk. So from esophageal cancers to gastric to lung to throat and bladder. I mean, it's all so don't smoke. And there are certain viruses that can predispose us to cancer. The poster child being HPV. So cervical cancers of the oropharynx. They come from HPV. Not all of them, but most of them. And then gastric cancer, certain of those cancers can be predisposed by H. pylori. I think that for the most part, if you get vaccinated for HPV, if you don't smoke, eat healthy, use sunscreen, you can prevent quite a number of cancers. Not every cancer, because there are different different etiologies and reasons for them, but I think that there isn't going to be so one of the reasons we get cancer is we get old, right? So we can't prevent that, but there are preventable things, as you mentioned, and I think that's a fair thing to focus on.
It's kind of interesting you said getting old, and now a lot of the longevity literature that you're reading is they're actually classifying aging as a disease, right? Yeah. So it's the disease of aging, and all the other things, we're treating them differently, right? So we're treating hypertension, and we're treating cancer, and we're treating stroke and all. Yeah. But if we treat the aging piece, those should fall away is the theory, the hypothesis. So we'll see where that one goes. Yeah. If I could live long enough, we'll see.
In terms of checkups, I know somebody mentioned the USPTF, like the website for things like that. Yeah. Do you recommend using that website for checkups, like for endoscopies, breast cancer screening, stuff like that?
I think it's a very good website. It's based off of literature, research, and very qualified people sit together and they come up and they come up with these recommendations that are published on that website. So I would say absolutely check that website out. We tend to recommend that for our patients too.
Somebody asked too, there's so many different types of cancers obviously, but is there anything that you see progress-wise with certain things that, or I guess maybe kind of what hinders the progress with things like glioblastoma and pancreatic cancer?
Yeah, those two are the big ones, right? I mean, we haven't made a ton of progress there. So for the GBMs, or the glioblastomas, the main hurdle is trying to get drugs into the brain, because there is this so-called blood-brain barrier, which doesn't let drugs get into the brain. So so the first hurdle is to actually develop something that gets to the tumor to kill it, right? Because a lot of stuff we have doesn't even get there. So what we are using is surgery and radiation for the most part. We do have some drugs now that have come up more recently that are targeted drugs that actually do penetrate the blood-brain barrier, so they're more effective. But we're still finding the disease pretty late, and there's no screening for GBMs. It's still a pretty rare disease. So we find, we tend to diagnose patients late, and then our tools are pretty limited. And the reason the tools are limited is because of that barrier that we have in trying to get the drugs through. There's a lot of work going on, though, and I think the future is very bright for that disease, too. I think it's probably GBM is where maybe lung cancer was 10 years ago. And, I think over the next 10 years, we'll have effective treatments for GBM, too. As far as pancreas goes, that, too, is a disease where the microenvironment where the cancer cell lives, it's drug delivery seems to be a difficult issue there too. But the other thing is we haven't found any good targetable mutation. I mean, we have mutations within the cancer cell, but we haven't developed any effective therapies for the mutations that the pancreatic cells tend to harbor. But again, I think there's so much research going on in that particular field as well. In every quarter, we get something exciting. So things are going to keep getting better. I mean, I graduated in 2010, and I can tell you it's a different world in oncology today. I mean, 15 years, it's like, pancreatic cancer we had one chemotherapy drug, literally one drug, and that was cutting edge. I mean, we used to tell people, if we give you a drug, so if there were stage 4 pancreatic cancers, we could improve your life expectancy by 6 weeks or 8 weeks if you took the drug, and that was considered as an advance. So we've come a long way. There's a long way to go, but I don't want people to lose hope. I think there's a lot of exciting stuff coming.
And kind of going from there, the next kind of couple questions, maybe a couple things we touched on, but somebody asked, how does the basic way, how does cancer spread?
So it's a kind of it's a long answer, but I'll try to keep it short. So cancer is just an overgrowth of our normal tissue, right? So it's not a foreign thing. It's just essentially what happens is the control mechanism fails. Right. So we can't stop our cells from growing, and it's just uncontrolled growth. So this is just our normal structures within our body that have just lost control. And how do they spread? Well, you have a cell that breaks off, gets into the blood pipe, and then takes a hike, and then it exits into the lung or the brain or the liver and the bone, and it just makes a new home over there. It's a living cell that has the capacity to make 2 and 4 and 8. So you have one rogue cell that breaks off from the mothership, takes a hike with the blood, exits into the lung, and thinks lungs is a good place to live. It's like a suburb they like, right? So they raise a family in that suburb, Right. So that's, some cancers, tend to have a very particular predisposition to where they're going to go. For instance, prostate will always like to go to the bone.
Mm-hmm.
So people are working on those homing mechanisms as to why it's only the bone, why not someplace else. So that's, work still in progress. But how they spread is very simple. I mean, the cancer cell is just going to break away from the main structure, and it's a living thing, so it's not going to die because it broke off, and it's going to find a place, someplace else.
Another question asked, autoimmune disease and cancer. So some people, there's autoimmune diseases that predispose you to getting cancer. Do you think that, I guess, research-wise, do you think that those are, really linked? And you think that the more progress with autoimmune diseases, the better for certain types of cancer as well?
So I think autoimmune diseases really is a reflection of a dysfunctional immune system, right? So it's not the disease it's causing cancer. It's the fact that your immune system is wacky because it's fighting yourself rather than fighting some bugs, right? So in a dysfunctional immune system is not going to be able to fight cancer, right? Mm-hmm. It's just dysfunctional. So if like I said earlier, in the talk, that we've all have had some, cancer cells develop in our system, but, the immune system gets rid of them. So if you have a dysfunctional system, then it's just a poor system to control that. So, and then the drugs you take for the autoimmune diseases, I mean, those are going to suppress the immune system even further. So then that's a dysfunctional immune system too. So, yeah.
And stress and autoimmune diseases are linked hand in hand. So nip it in the bud.
One final question.
Okay.
We kind of touched on this earlier, but HPV and EBV, somebody asked, do you classify those as a contagious disease? Because, for example, HPV could be sexually transmitted. Do you classify that as kind of an infectious disease, or is it more just something that's, obviously you encourage to get the vaccine for the certain subtypes, but do you think it's still kind of considered contagious in a way? If you get it from a partner, it could lead to cancer down the road?
Yeah, I think the viruses are contagious, but the cancer is not, right? So you have the virus, you can get it from someone else, but if someone's already developed cancer because of the virus, they cannot get cancer from you. I mean, you cannot spread the cancer per se, but you can spread the virus. And so, a proportion of people, which is not a very large proportion, but still a decent proportion of people, will eventually, can get cancer from those viruses.
Right.
But
yeah, I think they're leaning on, is cancer contagious? Well,
yeah.
They're making a leap.
Yeah.
You can get
no,
the
cancer
virus.
for the most part is not, because if we've all heard of the term rejection, right? So if I donate a kidney, it's a healthy kidney, it doesn't have any cancer in it. If I put this in someone else, it's going to get rejected. Right. So if I put my cancer cells into some other body, that other body, if it has an intact immune system, it's going to reject it because it's not their cell. Right. And so you really can't. Cancer is not really contagious, so you can't get it, through physical contact.
From that perspective, I think it was interesting. Like this year, we learned how there's the different stages, right? Like if you get HPV, you have the epithelial neoplasia, then you actually get invasive cancer afterwards. So I feel like that's kind of just very interesting too, to see how many different layers there are of cancer and how the immune system is really effective at fighting it off. But like you said, if you don't have the immune system, you don't have that.
Yeah.
So,
Dr. Saghir, a pleasure. Faisal, always nice to see you.
Pleasure's all mine. Yeah, it's always good to see you.
Thank you for the discussion.
Absolutely. Thank you very much.